Great. I think we're going to get started, and we certainly do not want to get finished too late. So, welcome to everybody that's joined. I can see more people are coming in. We're already more than 15 on the call, and neonatal care always seems like it's something that should be happening in fancy, posh hospitals very far away. But of course, is one of the key programs when you're in rural health, and similarly to obstetric health, is can be one of those really stressful things when you have a sick baby late at night, and decisions that you make have to be made quick. And it's those first 30 days we have to get things right, or things can go wrong very quickly. So I'm very pleased tonight to have one of our big rural health advocacy stalwarts, and especially in the world of neonatal care, which is Dr. Michaela Lotz. They've been at Madwaleni. I'm sure she can tell us how many years they've been there. I used to remember seeing her and her husband when we used to go and visit. And she is really committed to a rural hospital and to rural health care, and has taken a real special love and interest in providing the best possible care for neonates in a resource poor setting. And I think that really is in the spirit of this rural onboarding program, that we're trying to look not at just generalized skills and understanding, but what is specific to our rural health settings. So I'm going to hand over to Michaela now. Just remember, please, to give me who you are, where you are from, what you are doing, and your email address, especially if you want the links to the recordings and any other materials in the next few days. Michaela, I'm going to hand over to you.
Thanks, Madeleine. Hi, everyone. Thanks for joining this session. My name is Michaela Lotz, and like Madeleine said, I work at Madwaleni District Hospital. I'm not a pediatrician, but I have had the pleasure of being part of the Madwaleni team as we've grown the neonatal service at our hospital over the last 6 years. And so I'm hoping that I can share some of the tips that we've learned along the way, and that I can encourage you to build your service where you are. And point you to the many great resources that there are available for neonatal care in our settings. So to start, the outline of the talk, we're going to look at the numbers, the neonatal mortality numbers, and what the causes of death and neonatal deaths are in South Africa. We're going to look at some of the strategies to reduce neonatal deaths in South Africa. I'm going to tell you a little bit about our context at Madwaleni, and then we're going to really touch on a few things. Neonatal care is a really big topic, and so I've tried to make it specific for the causes of death, of neonatal deaths in South Africa. So a little bit about resuscitation, some tips, prematurity, safe oxygen therapy, neonatal sepsis, managing seizures, two life-saving skills that we'll just go through with a video, and then feeding to end off. So we're going to start now. Great. So the numbers, when we look at our neonatal mortality rates in South Africa, there are many different sources that provide the data. There's the perinatal problem identification program, which is like CHIP, but PIP. There's our district health information system, which gives us information from our public facilities. There is our vital statistics, which is our death and birth notifications and registrations. And from that, there's the rapid mortality surveillance that's produced, that gives us estimates. And then surveys every 5 years, the demographic health survey gets done. And the last one was in 2016. And so from these different sources, they estimate our mortality rate, which is in South Africa, 11, according to the rapid mortality surveillance, and 21 according to the demographic health survey, which may probably overestimates the mortality because it includes stillbirths, because it's a questionnaire based source. So that's South Africa, but in the Eastern Cape, many of these sources don't get disaggregated down to subnational level. And so the most recent stat that I could find for the Eastern Cape was 15.7 per 1,000 live births, which is from 2011, which is quite a while ago. Remember that the Sustainable Development Goal for neonatal mortality is 12 per 1,000 live births, and this forms part of the Sustainable Development Goal 3, which is to end preventable deaths in under fives by 2030. Cool. Then looking at this graph, sorry, I think I've messed with this thing. This graph shows the causes of mortality in neonates, and you can see for the let me make a pointer. That's for this group of more than 1,000 gram babies. The top causes are intrapartum related events, that's asphyxia, prematurity related deaths, and infection. And these are the same causes of death that they're the same as 2012. They're our main causes of neonatal death, and they remain that way. This is information in this graph is to show you that the burden of premature deaths over here, and the burden of intrapartum related injuries, the greatest burden is at district hospital level, which is where I'm working and where many of you are working, and that's where most of the babies are born, and that's where the burden is. So it's it's very relevant to us to look at these things and to improve our care. So the happiness strategy came out of the recommendations from the National Perinatal Morbidity and Mortality Committee on Saving Babies. And it was a strategy to reduce neonatal deaths, and its implementation formed the basis of the Neonatal Survival Strategy, which is the NES in the happiness. So HHAPI stands for improving the health system for mothers and babies, improving the skills of healthcare providers in maternal and neonatal care, reducing deaths due to asphyxia, prematurity, and infection. And I just wanted to touch on a few of these points that are guiding the talk tonight. So training of healthcare workers in ESMO, including helping babies breathe, and MSSN, which, if you haven't heard of it, is managing sick and small neonates. And so these are training courses to improve maternal and neonatal care. For asphyxia, reducing deaths is about making sure that all birth attendants are skilled in the use of neonatal bag and masks. Prematurity, ensuring that appropriate hospitals can use nasal CPAP and have that available, and ensuring that mums have easy access to KMC. And then reducing infection, promoting breastfeeding, and ensuring that presumptive antibiotic therapy is given for at-risk neonates. Okay, so this is what we're kind of going to be basing what I focus on today. Access to appropriate care is a very, it's like a very rural problem. Our patients not only have problems with accessing level 3 facilities, NICU. This is us at Madwaleni, and we are an hour and 40 minutes away from Nelson Mandela on a partially tarred road. But our patients struggle to access us as well for skilled birth attendants, for monitoring in labor, and accessing nasal CPAP, depending on which facilities have that available. We recently did an audit of our transferred neonates, and we calculated a 26-hour average waiting time from first discussing a patient for transfer to the arrival of EMS to collect the neonate. There are lots of different causes for the delays in being able to transfer patients, from the availability of advanced paramedics to transfer, from availability of beds in overburdened level 3 facilities. And so these all contribute and basically encourage us to build a better service where we're working. So this is the Madwaleni story, or the improvement. So when I first arrived at Madwaleni, the neonates were being cared for kind of in the middle of maternity ward. We moved on to create a 3-bed KMC ward in maternity ward, still with our sick neonates being monitored in the middle of the chaos of labor ward in the delivery room. And now through much work and over a long time, it's been 6 years, with multidisciplinary team input and district support and help with equipment, we now have a neonatal high care unit, and we have separate KMC room or ward with dedicated nursing staff and CPAP, packed oxygen, and even a Prem tube to breastfeeding protocol that's was started by a speech and language therapist. And so this is to encourage you that wherever you are, little steps along the way. It didn't happen fast. It was like a recess box, and then it was some stationery, and yeah, just to encourage you what can be done. And we're still working to improve our care. We're not perfect. Okay, so this is to show you point out the amazing resources that are available for neonatal care. Madeleine shared them on the link, which stands for Limpopo Initiative for Newborn Care. There is this tab, Health Worker Resources, where you can find the newborn care charts, which is the management of sick and small neonates. And you can find amazing resus manual, the newborn transition and neonatal resuscitation manual with very cool videos that goes through ventilation, intubation, and a whole lot of steps. I'll show you one of the videos, but just know that those are available and go and look for them. And I'll refer to a lot of them in this talk. Okay, so starting with resuscitation. The first point about resuscitation is that most babies don't need resuscitation. So this is data from 2 Gauteng hospitals that showed that 3 to 6% of newborns needed help with breathing, 0.1% needed cardiac compression, and 0.04% required adrenaline. And this over here is the Helping Babies Breathe algorithm. It is an action plan with steps that offer a systematic approach to the care of a newborn after birth. And the idea is that if correctly applied, these can be effective within the first minute, which they call the golden minute, for starting ventilation for a baby that is struggling to breathe. And so when we look at this and about the need for resuscitation, the tips are that if you're going to focus on something, focus on getting ventilation right and doing that well, and mastering that. And the other tip is, if you're not doing something often, have the resources really easily available so that you can refer to them when you're in that emergency situation. So have your adrenaline doses like available clearly for you to see, have your Helping Babies Breathe algorithm up on the wall, so that you can refer to them in those situations. Okay, so being prepared is my number one tip when it comes to resuscitation. This is our neonatal recess box, which we had one box and that traveled between labor ward and Caesar ward, and now we have a box in each of our in theatre and in our labor ward. And basically it's a toolbox, and it has a checklist. There is a checklist available on the link website, and it does everything we need for resuscitation, and we know that we'll find everything we need there, and that really helps, has helped us. And so yeah, it might be something that you can implement in your facilities. The other part of being prepared is having staff available when you expect to need to do a recess. And so for fetal distress, for emergency Seizures, for premature babies, have extra hands available for those situations. The second point is to capacitate your team. So it doesn't help if only the doctors in the team know how to ventilate a baby with a bag and mask. We need to be capacitating our midwives and nurses and everyone that's involved in the deliveries to be able to start that ventilation within that golden minute. And so it's really worth going through that with your team that you work with. And then, like I said, easy to see resources are really helpful. Have your ET tube sizes according to weight and your depths, and so that you can just look at that quite quickly when you need to. Okay, so we spoke about ventilation being a really important ventilation as soon as possible for a baby that's not breathing well. And I wanted to just talk through it a bit. So the baby not breathing well, if I go back to this, so this is the baby not crying, and this is the baby not breathing well. And so your steps are to clear the airway. I like to remember M before N to remind me to do mouth first before nose, and try not go too deep to avoid vagal stimulation, which will cause a bradycardia. Stimulate the baby and then start ventilation. You don't need to start with oxygen straight away. You can use room air to start. There are really good tips on good bag and mask ventilation and how to improve ventilation on the LINC website. To talk through it, a neutral position is needed for a neonate that you're ventilating, and a cloth under the baby's shoulders can help you create that neutral position. Make sure you have correct size masks. So in your toolbox, have different size masks. Prems, term babies, it must cover the chin, mouth, nose, not the eyes. And then this is an example of the best way to hold the mask with your index and thumb on top, with your third finger lifting the chin and your fourth and fifth on the jaw to create a good seal. And then you're bagging at a rate of bag 2, 3, bag 2, 3, which is 30 to 40 breaths per minute, looking for chest wall movement. So you're using enough air to create chest wall movement, not trying to squeeze all the air in the bag to prevent barotrauma. Yeah, and you're looking for a response in heart rate and the baby breathing well. And then I wanted to just talk about if you're lucky enough to have a Neopuff infant ventilator available, that it's really helpful to set your ventilator when before the baby's born or during the delivery, so that you know that at a certain flow, I like to use 10 liters per minute, your PIP, which is your peak inspiratory pressure, will be 25, and your PEEP will be 5. And if you set that and then switch off the oxygen, then when you need it and you switch on the flow again, you know that your settings are correct and safe for ventilating the baby. Okay, just a few tips about advanced resuscitation. So if a baby is not responding to ventilation and your steps to improve your ventilation, then your next decision begins with an assessment of the heart rate. If your heart rate is less than 100, you continue your effective ventilation. And if your heart rate is less than 60, you start chest compressions. So these are the two different ways in which you can do chest compressions, and the ratio is 3:1. We'll talk a little bit later about intubation. And then adrenaline doses, nice to have up, like I said. Intravenous is best, and an umbilical vein catheter is an option for intravenous adrenaline. You can also use an ET tube with an undiluted adrenaline. It must be a higher dose than IV. And if it isn't effective by the ET tube, followed by bagging, then you try and give a repeat dose when you have IV access as soon as possible. So that's just a little bit about advanced resuscitation. Like I said, there's a very cool resource manual. Go and have a look at it. It's got lots of detail and lots of videos. We are going to move on now to looking after premature neonates. So just to start, remember that preventing deaths due to prematurity starts antenatally. So maternal care is very linked in with neonatal care, and good antenatal care and antenatal corticosteroids for preterm labor, and transferring in utero, extremely low birth weight babies in utero rather than post-delivery. These are all things that we can do antenatally. Looking after prems takes multidisciplinary teamwork. We have so much help from our multidisciplinary team in terms of premature workshops that they do with mothers, which helps with education. They help with KMC wraps that they make from bed sheets, which facilitates better continuous KMC. And they run a high-risk baby clinic where they follow up prems until corrected gestational age of 1 year. Also very involved in the prem feeding protocol, which was what I referred to earlier, which is a protocol which helps to transition babies from prem babies from tube feeding to breastfeeding so that they go home breastfeeding. Okay, so looking after prems is all about paying attention to detail, and there is very good guidance from admission through to discharge in the neonatal care charts, or the MSSN book on page 52 to 53 for each weight category. It just breaks it down and is a great resource to check that you're doing everything that you need to do. Some points about admission: always think about how you're going to prevent hypothermia. So know your incubators, whether they're servo controlled, whether you use a skin probe, whether you have a manual incubator. Do you need to set air mode? In the same newborn care charts, they have a table that you can use to work out what the temperature setting should be, according to how old the baby is and the birth weight. And so that's really helpful. We use that a lot. And then KMC is obviously also a way to prevent hypothermia. Preventing apnea should always be part of your admission for prems, for babies that are less than 35 weeks or less than 1.5 kilograms. Decisions about oxygen, we'll talk about that on its own. Decisions about antibiotics, we'll talk on their own. Fluids and feeds is a very, again, detail working out feeds, but there are great charts in the MSN care charts book that you can print out and put on the wall that you can refer to. It literally gives you day 1, day 2, how to transition from IV fluids to feeds. And yeah, those are really helpful resources that you must definitely be referring to when you're looking after prems. And then growth. Most of our prems, once they are stable, they stay with us and they are there to grow, or they're discharged from another facility to grow in our KMC wards. And so it's nice to know what good growth is and what's expected. So remember that for all babies, they can lose 10% of their birth weight in the first week, and that's completely expected and normal. More than 10% is concerning and is considered significant weight loss. And then expected weight gain is that they would have gained that weight and be back at birth weight by 7 to 10 days. And thereafter, minimum weight gain should be for a prem 10 grams per kilogram per day, and for a term baby 20 grams per kilogram per day. Yes, just check if I wanted to say anything else. One of the tips for fortification of expressed breast milk with prems, if you don't have FM85, which is a fortification that you use for 1 scoop for 20 mils of expressed breast milk for babies that aren't growing well, you can also use olive oil. We've done that before. 0.4 mils or 20 mils of expressed breast milk is the dosing. It's 2% of the feed to add oil. Cool. Then how do we respond to inadequate weight gain? This is straight out of the MSSN book, and just is a reminder of the things that you need to be thinking through when a baby isn't gaining weight. So there's serious illness, which obviously needs its own action and response. But also checking insufficient feed. So have you calculated the volume correctly for weight and age? Temperature control. Is your temperature control appropriate for the size and age of the baby and the birth weight, especially your less than 1.5 kg babies? And incorrect feeding methods. Is a less than 1.5 kg baby breastfeeding only? That's inappropriate, and that baby should have a feeding tube. And so those kind of checking your feeding method and correcting these things is a response to inadequate weight gain. Okay. And then discharge is as important as anything that happens during that mission. We've usually spent lots of time stabilizing a prem and growing with us. And it would be very sad if if you don't discharge and prepare that baby for a good discharge. Yeah, so discharge criteria, the MSSN gives guidance about when you can be sending babies home. They use the weight of more than 1.8 kilogram or between 1.8 and 2. They must be clinically well. They use KMC scoring. So in the book as well is a KMC score chart, which doesn't only look at KMC, but looks at feeding and milk supply and like confidence the mother has in caring for her baby and social support at home. And so it's a really nice holistic look at a mum and her like readiness for discharge. And you can refer to that as well. And then at Madwaleni, we use you must be gaining on exclusive breastfeeding as one of our discharge criteria. Supplements, don't forget supplements for 6 months for prem babies, multivitamin and iron. You may have a different formulations of iron. So we have ferrous gluconate at Madwaleni. You may have ferrous lactate or ferro drops. And it's just something you need to check your dosing because it depends on the elemental iron. Multivitamin is pretty standard. Immunizations, sometimes babies have been with us long enough that they need their 6-week immunizations. So think of that when you're discharging. Make good weight check plans. So what we do is we review in a week, weekly until baby is 2 kilograms, and then 2 weekly until 2.5. And that is like a safety net for checking up on those babies. Remember, just because they're 1.8 kilograms doesn't mean they aren't a vulnerable prem still. High-risk baby clinics. So I spoke about the high-risk baby clinic that our rehab team run here. But all prems should be followed up at 4 months and 9 months for a neurodevelopmental assessment. And that is great if it's done as part of a multidisciplinary team. Good documentation in the Road to Health card, which is going to be with the baby. And if you don't put it in the Road to Health card, that information is probably going to be lost. So document well on discharge. And then I wanted to say that about the discharge criteria, it's really worth explaining to moms and educating them early about what your goals are and what the plan is, so that they can adjust their expectations about when they'll be going home and when baby will be ready, and they can partner with you rather than you having to fight with moms that are really desperate to go home, which is fair. Okay, talking about safe oxygen therapy. So I don't know at your facilities what different ways you have for delivering oxygen, but head box oxygen is something that we don't use here because we don't need to, but the MSSN has some nice guidance about how to use head box oxygen. This is a nice table that shows as you increase the flow, you can increase the FiO2s that you're delivering to a baby that needs it. Another point I wanted to make on this chart was that remember that nasal prongs at 1 liter per minute is giving you a concentration of FiO2 of 30%. And so that's nice to just remember. The most important or an important thing to think about when you are delivering oxygen to a neonate is what your targets are. And so neonates don't need to have SATs of 99%, but for a prem, the SAT should be between 90 and 94, and for a term baby, 92 to 94. And remember, there are dangers to oxygen therapy in neonates, especially prems, because retinopathy of prematurity. One of the tips about delivering oxygen is depending on whether you have wall oxygen or cylinders, have backup cylinders ready. So if they need regulators, have cylinders ready, full cylinders ready with regulators, or have spanners available, easily accessible to change regulators, because there really is nothing worse than a baby that is desaturating and you can't get the oxygen. So it's one of our rules in our neonatal unit is to have a spare cylinder that we know is a backup oxygen supply. Yeah, and babies that are on oxygen should be on continuous monitoring, but that isn't always possible. And so something to consider is to use it continuously for 30 minutes initially when you start, and then to do SATs at least hourly. Okay, nasal CPAP has made an amazing difference to neonatal care at district hospitals, especially for preterm babies with what used to be known as hyaline membrane disease and is now referred to as respiratory distress syndrome, and also for babies with apnea due to prematurity. There are many advantages. It delivers oxygen, provides positive airway pressure to prevent collapse of airways, which then decreases the work of breathing, optimizes surfactant production, reduces and then also can reduce the incidence of apnea. One of the important things, if you have nasal CPAP available, is to use it as soon as possible for prems with severe respiratory distress, because they do better if it started earlier. So especially for less than 34 weeks and less than 1.8 kg babies, if you have it available, use it as soon as possible. Some tips is at Madwaleni, when we take a baby off of CPAP, we put a clean circuit on, and we tape up, and we put the patient interface in its bag, and we tape it up so that everybody knows that that's a clean set, so that when a baby does need CPAP, you're not having to set it up in that like particularly stressful situation, and those circuits are ready. And the other thing we do is put in orogastric tubes to prevent gastric distension. Some tips for your settings. So it's nice to start at 60% FiO2 and then make sure your pressure is at least 5. Always use your lowest possible FiO2. So initially wean by 10% every 3 minutes, aiming for those targets that we spoke about. So 90 to 94 in prems. And then when you're weaning a baby off of CPAP, wean FiO2s first and then pressure. This is a link to, which I'm not going to open now, but Madeleine will share the slides with you, is for how to make bubble CPAP. If you don't have the CPAP machines available, using nasal prongs, oxygen tubing, and a bottle of water. It explains it really nicely, and we've used it in our peds ward before as well. And so that video might be a really good resource if you don't have CPAP available. Cool. Moving on to a little bit about neonatal sepsis. So presumed neonatal sepsis is something that we admit babies for really often in our facility. The MSSN guide gives some guidance about who should get antibiotics, and that's over here. Your babies that are less than 1.5, babies from potentially infected environments, chorioamnionitis, and babies with obvious signs of infection, babies that are less than 37 weeks with no obvious reason for preterm labor. So that's not a preeclamptic that needs a Caesar and has a preterm baby, or gets induced because of preeclampsia. That's a spontaneous preterm labor, where you assume that the reason for spontaneous preterm labor, the biggest reason is infection. And then babies with respiratory distress, obviously. So early neonatal sepsis is within the first 48 hours, and it's usually group B strep or E. coli, which is covered by PNG or ampicillin. You can use either, and then gentamicin and aminoglycoside. Remember that in neonates, they can present with specific features like respiratory distress or bulging fontanelle, or they can present with very non-specific features like lethargy, apneas, poor perfusion, poor feeding, high or low temperatures. And so, yes, watch out for infection in neonates, because it can be really serious. So what we do and what MSSN suggests is starting antibiotics for at-risk babies, and then doing a CRP after 48 hours and stopping antibiotics if the CRP is normal and the baby is doing better. And what we do is we continue for 5 days if the baby is improving but has a high CRP. I think the tip is to rather be safe than sorry, and to rather start antibiotics for babies that are at risk. It is worth the admission, and it is worth the IV line for antibiotics. Yeah, rather be safe. Okay. Then a little bit about managing seizures. I know I'm sending a lot of information your way, and sorry, it's lots to cover. But when it comes to managing seizures, remember that they can be quite subtle in neonates, and they need treatment if they're recurrent, they last more than 3 minutes, or they cause cardiorespiratory compromise. One tip is to differentiate jitteriness from seizures, that seizures don't stop when you flex the limb, whereas jitteriness does. It's the most important thing is to find out what agents you have available in your facility. There are lots of different algorithms for managing seizures, and it's really based on what you have available. Phenobarbital IV is first prize for first line, but we've been struggling to procure it, and I don't know if other facilities are as well. And so we've had to make other plans and use other agents. Another option, if you don't have IV phenobarb, but you have oral, is to use a stat dose of Midazolam and then load orally with a bigger dose of 40 milligrams per kg, crushed, mixed with water down an NG tube. Then I just wanted to talk about a few points about each of the agents. So Phenotoine has a nice way of remembering it: 20-20-20, 20 mils per kg and 20 mils normal saline over 20 minutes. Don't give Phenotoine with dextrose containing fluids, which includes neonatalite. Remember, neonatalite is 10% dextrose, because it precipitates, and yeah, so don't use it with dextrose containing fluid. And remember that you cannot use lignocaine as an agent and Phenotoine within 72 hours of each other. And then this is really a really cool regimen for using Midazolam as an infusion, which we have done a few times. And this is much simpler than actually what we've used before. And this comes from the neonatal guidelines and the app that Madwaleni shared with you as well. And so I just put this here in case someone needs to refer back to how to use Midazolam. Okay. Okay, then talking about some life-saving skills, intubation of a neonate. There's a list of what you need to do the intubation, what you should have ready. Just wanted to emphasize McGill's forceps and how helpful that is and how necessary that is for intubating a neonate. This is the McGill's forceps. When we arrived at Madwaleni, we didn't have neonatal McGill's forceps, and we ended up buying them. And I've actually recently seen them on Loot for sale, neonatal McGill's. So if your facility doesn't have one, maybe you want to buy one and make sure that you have one available, and you all know where it is. Nasotracheal intubation is a better idea in neonates. It's easier to secure, and it is much better for when you're transferring a baby. And my other point was that this kind of chart, which shows you your ET tube sizes and your depths, is really nice to have available. So we've got it on our recess box, so that it's something that you can find very quickly when you are needing to do an intubation. Another quick way of working out your ET tube is your gestational age in weeks divided by 10. And that's just like a quick way of working it out. I want to show you a video now. I'm gonna have to work out kind of how to do it. So I'm gonna stop sharing. And then I'm gonna share a different screen. Okay, so this is one of the link videos, and this one is on intubation. I wanted to show you how great they are, and yeah, it's a nice one to watch. Can you hear? I don't think I did the right thing for sharing with sound. Sorry. Okay, let me know if you can't hear.
And then you take your...
Oh, didn't start it at the beginning.
Back to 3, back to 3. There may be an indication for intubation. So the indications are indicated in the manual. So make sure that the baby continues to be ventilated. You must check that you have all the equipment. You must have the suction, the right side tube, laryngoscope and blade, make sure it's working. McGill's forceps, strapping, and a Caesar. So first you must suction the baby in the nostrils, and then after suctioning, you must insert the right size endotracheal tube into the nose until you feel a give. That means you have gone past the palate and you'll be able to pick up your endotracheal tube with the McGill's forceps. Then you take your laryngoscope blade and then insert it into the right, moving the tongue to the left. Then depress the tongue and then tilt. Use your McGill forceps to hold in the tracheal tube and insert it into the vocal cords. Then you make sure that the tube is in the right place by inflating. Okay, then you should see the lung expand. Back to 3, back to 3, back to 3.
All right. Oh, sorry. Oh my goodness. Sorry.
While Michaela's getting her shared screen ready, if you do have any questions, do feel free to put them on the chat so long, or you can put your hand up and we'll cover them once she's finished her presentation.
Sorry. Back. You can't see my screen at all.
Not yet. No, not yet.
Sorry. Okay, back.
Yep, there we go. We can see it now.
I just need to get it back to where I can see them. Okay, sorry. So that's our intubation. And the next skill I wanted to talk about is umbilical vein catheterization. And this is a cool diagram from the link resource again on how to do that. Remember, it can be done in a neonate up to 7 days. These are the steps that I thought I would go through just quickly. Remember, it's a sterile procedure. You don't need a special umbilical vein catheter. You can use a feeding tube, so a nasogastric tube. And it's an important step to connect it to a syringe containing saline and to flush it so that you eliminate any free air. The next step is to place the umbilical tape around the the umbilicus, and you don't need to have special tape for that. We use suture material, and we find that Vicryl works better than nylon because it doesn't slip as easily. What you do then is you cut the cord at 2 centimeters and you identify the umbilical vein. One umbilical vein, you can't see my pointer, one umbilical vein, 2 umbilical arteries, and you are aiming to go to the vein. So you insert the tip of your saline-filled nasogastric tube and you advance while you aspirate looking for blood return. And once you see blood, you insert the catheter 1 to 2 centimeters beyond this point. And then that's an appropriate position that you can use in an emergency with us confirming it radiographically. Securing the strapping, I suggest using rugby post strapping, which is this. And you can also secure your suture material down here and then lay it flat on the abdomen with the OBSite. And that's a really cool skill to have when you are struggling with IV access, especially in an emergency situation. Cool. I can't do a talk on neonates without talking about breastfeeding. This is a quote that I really enjoy, which says that even though it's a natural act, breastfeeding is also a learned behavior. Virtually all mothers can breastfeed, provided they have accurate information and support within their families and communities and from the healthcare system. And so that's like a really cool, just really points out that breastfeeding mothers need support from everybody. The WHO 10 steps, which are displayed here, really cover everything from antenatal care to care right after birth to support with problems to discharge and creating support and accessing resources for mums to support breastfeeding. At Madwaleni Hospital, we did a small study where we followed up low birth weight babies. We followed up the feeding methods, and we found that the most high-risk period for introduction of alternative feeds was the first months, which is quite early. The most commonly reported reasons for introducing feeds was the perception of insufficient intake, that it wasn't enough, and on advice from family and healthcare workers. And it's really cool to take these points into consideration when you are supporting breastfeeding, and involve the family in your breastfeeding promotion and give advice on the signs of a baby getting enough milk, like wet nappies and growth, and address myths like the need to add formula to a baby's diet at 6 months, and make sure that moms understand that that isn't necessary, and its complementary feeding doesn't include formula feeding. There is also a really cool training course or a manual that you can read through that's available. It's a WHO on the WHO website, and I've put the link in the references. And that really gives you more detail about how you can really practically support mothers in breastfeeding. And if you didn't think that breastfeeding was important, then I wanted to show you this, which is the Lifesaved tool. It's a software modeling tool that can be used to estimate the impact of scaling up interventions on maternal and child health outcomes. And it showed that as a preventative intervention and with universal coverage of 90%, breastfeeding was shown to have one of the biggest effects on under 5 child mortality in 42 countries. And so you can see the list here of interventions that it's compared to, and breastfeeding saves the most lives out of the preventative interventions. In South Africa, they showed that at 95% coverage, breastfeeding promotion is the top intervention for saving children's lives, and that was in 2015. And so it really is important, and it is really worth spending time and energy on in helping mums to establish breastfeeding and continue breastfeeding appropriately. Cool. So just some take-home messages. You've listened to me for long enough, sorry. My messages are: take time to get prepared. So prepare your resus equipment, and prepare your areas where you look after neonates with the resources that you need to care for them well. Use available resources. There are so many resources specifically created for district hospital care that are really relevant to the work that we're doing and caring for neonates at our level facilities. And then the last point is to keep building your own service where you are working and keep trying to improve it. I'm showing you this picture because this is a baby that got surfactant at Madwaleni, which is our latest thing that we're trying to get access to. And yeah, we've had it, trying to secure access so that we have it whenever we need it for very low birth weight babies with respiratory distress syndrome. So that's the next exciting step in our service. Cool. So these are some of the references I used and the resources to the different resources that I referred to in the talk, as well as the breastfeeding one, which hasn't been sent on any of the emails yet. So yeah, have a look at those. Thanks very much for listening. Yeah, thank you for your time. I hope it helps you to help babies where you are.
Thank you very much, Michaela. That was definitely spot on. I think in terms of what we need to, especially not only just all these wonderful tips, but also a way forward on how to actually become an expert on neonatology. It's not something one learns in an hour. And a huge shout out for Limpopo for those amazing resources. That's really nice to see local grown, sort of rural grown, available materials and resources. So what we're going to do is, Michaela, I'm going to ask you to send me your presentation. And then I will put together, once we've put the recording onto YouTube, we'll put it all together in one email package, which we'll send out to everybody, and which we're very happy to be distributed for people to learn further. I'm just looking, there's no questions that I can see on the chat as such. And I'm just seeing if there's anybody that has their hands up. I've got a hunch you've managed to touch on all the really big essential things. Michaela, if there's anybody that's got a question, they can either put a hand up or unmute themselves. But it looks like there's no burning concerns at the moment. If you haven't yet, please do write your, just who you are, where you're from, what you're up to, and your email address in the chat section there. I will download it at the end of the session, and that will help us when I email out all our information. It doesn't.
There's a question about the ET tube, the internal diameters, and that little formula that I spoke about. It's gestational age in weeks divided by 10. So if you have a 35-week-old baby, you divide it by 10, you get a 3.5 internal diameter size ET tube that you need for that baby. There you can use that, or you can use like there are various charts included in the link resuscitation manual, and which gives you a chart that has a bit more information than the internal diameter, also the centimeters depth that you need for different age babies, different weight babies.
I think a very useful tip is that getting ready. So having next to you, go through your resource trolley when you go through the materials, get all your little posters printed out, get them put up on the walls, have everything. Do that when you have a quiet afternoon. Not that there's so many of those, but you don't want to start running around 11 o'clock on a Friday night after delivery trying to find bits and bobs.
Yes, definitely.
Great. Just double checking the chat again. I think we are actually able to close the session now at 1 hour, which is perfect. Michaela, thank you so much for preparing all this work. It's not so easy to sit and write slides in between everything else that one has to be doing. It's really lovely to have had you part of this. And everybody, we will be sending around all of this information. Just give me a few days to upload it and put it all together. Hope you all have a lovely evening. Our next session, which is part of the Worcester Family Medicine tutorials, will be on Wednesday night at 5 o'clock. Prof. Wolfie Conradi and Dr. Janine Kirby, they actually run a 8-week course on preventing burnout and stress management and healthcare professionals. They're going to give us a taster of that on Wednesday evening, so please do join us. And then we will be sending out the Zoom links for the sessions next week by the end of this week. I think that's all from me. Have a lovely evening, everybody. I'll be on the call for another few minutes just doing admin. Otherwise, you can leave and join your families again. Good night, everybody.
Good night. Thank you.